line. Casey, are you able to show up and share your screen? Oh, great, perfect. Phew. Those techno, hasn't done it since, so maybe it was just Ned. Just kidding. But we are excited. So kind of when we were forming this SWAVO, we kind of wanted to go back to the basics. There's a lot of turnover in the victim advocate field. And sometimes you jump into a position and you're like, I don't know why we do this. And so that's why we brought in the lethality assessment again to come back this afternoon. And then the domestic violence fatality review actually was on a little hiatus and is now just kind of reforming again. So it was a great time to bring that in. So I'm excited that Casey is here to give us a good overview. And then Casey's partner, Teresa, will come here and we will actually get a practice a mock review a little later before lunch. So I'll turn the time over to Casey.
Oh, thank you so much. I'm so excited to be here. Thanks for this opportunity. And I apologize that I'm not there in person. I really wish I was, but I have our overdose fatality review at 10:30. So I'm kind of on a little bit of a tight schedule today, but thank you so much. This is awesome. So just a quick overview, we are the Department of Health and Human Services now, and our mission, of course, is to protect the public's health through preventing avoidable illness, injury, and disability, and also premature death. And we also want to make sure that we assure access to affordable, quality health care and to promote healthy lifestyles, because we want Utah to be a place where all people can enjoy the best health possible, and we can all live and thrive in healthy and safe communities. And we do so through our strategic priorities, including having the healthiest people, optimized Medicaid, and a great organization. So as Rachel mentioned, I am in charge of the domestic violence fatality review. So fatality reviews through the Department of Health and Human Services, we have both system reviews and prevention reviews, and I am in charge of all of the prevention reviews. So the purpose of a fatality review is to effectively identify system gaps and innovative prevention and intervention strategies. So the process for doing this, fatality reviews are a multidisciplinary process, which helps identify those risk factors and those circumstances that lead to a death. So in doing so, we utilize confidential information that we gather about the individual, and this is throughout their entire life cycle. We're looking for as much information as we can possibly get, and we want to know, where all those touch points were with all of our systems. So we do so by looking at drug use history, any comorbidities, major health events, ACEs and social emotional trauma, any encounters with law enforcement or the criminal justice system, and then, of course, their treatment history and any other factors that we're able to assess. And this helps us to have a deeper understanding of those missed opportunities for prevention and intervention. Because, of course, our ultimate goal is to prevent future fatalities. So we blend this information from public health and private health, from public safety, from providers, from the community, from our committees themselves, and we do this to develop those program and policy recommendations. Our goal is to provide those recommendations that can be implemented to help improve coordination and collaboration between our agencies and the community, again, to prevent those fatalities. Now, we do our data collection under a couple different ways, grandma request, of course, and then we have the injury reporting rule. We also do have legislation for our overdose fatality review, so that helps us gather that information. So just a little bit about our fatality reviews in general. So we conduct statewide fatality reviews, and I sit at the Department of Health and Human Services. So I conduct 5 different types of fatality reviews in the state, and I'll talk a little bit more about those in a minute. But I also serve as a consultant for additional fatality reviews. And then our team, me included, we serve as TTA providers for other national overdose fatality reviews as well. So the fatality reviews that we have here in the state are, of course, our domestic violence fatality review. We have a child fatality review where we review all of our child fatalities, 0 to 18 in the state. And then we have a child suicide fatality review, we have actually just formed this team. We used to do our suicides with our child fatality reviews, but we've broken that team out so that we can do a little bit more in-depth reviews on those cases. We've been collecting next of kin information, so it's allowed us to get a little bit more in depth. So we're doing those quarterly now, which has been really fantastic. And I'm grateful that we're able to do those. And then we have an advanced clinical child fatality review. This looks at our sudden unexpected infant deaths and sudden death in the young. And this is with a group of highly specialized physicians. We work with the CDC on this and categorize those cases. And we're also banking samples now for the National Repository, which is really fantastic. It's been a wonderful program to be involved in. And then, of course, we have our opioid overdose fatality review, which is where I'm headed next. So I'm going to speak today, of course, just about the domestic violence fatality review in depth here. So the primary purpose, of course, of domestic violence fatality review is to establish effective strategies and to improve agency and community response to prevent and respond to both intimate partner violence and domestic violence, as well as to cultivate discussion and action to establish a unified multi-agency approach to addressing this public health issue. So a little bit of a background, this was mentioned, but our domestic violence fatality review was actually established in 2002. The committee was comprised of only data providers, so it was a little bit different than what we have now. And those cases were reviewed once they were adjudicated. So that meant that some of the cases were reviewed a year or more after the actual incident. And that committee actually went on hiatus in 2018. And then I started with the Department of Health then in 2019, and we devised a plan to reestablish DBFRC in March of 2021. It took quite a bit of planning, but Teresa was phenomenal. She's really the reason that that was able to be reestablished. So it's been a kind of a passion of mine, and I'm grateful that we're back and reviewing these cases. I feel like they're so important. So our new committee is comprised of a very large group of subject matter experts. So some of those are data providers, some of those are non-data providers, but we wanted to allow an opportunity for a bunch of different subject matter experts to have the opportunity to review these cases, because all of these different perspectives are so very important. Excuse me. And the cases are now reviewed as they are identified. So I am looking at those cases as they're happening, and we are reviewing them usually within a month of them happening. And then we are just barely starting to re-review cases again. And these cases that we're able to re-review, it's because we have more information. We're able to get law enforcement reports. They do take a while for us to receive, but once we have those, that's a wonderful, rich information source. So we're able to re-review those cases and really refine those initial recommendations that we were able to develop when we initially reviewed that case. So as I mentioned, we have a very large, active and engaged committee. They are so wonderful. I'm so grateful for them. Ned is part of that team, so it's just a wonderful committee. A very small portion of those committee members are data providers, and they are the only ones who receive those case lists, and that's to kind of help with the confidentiality issues. These cases are often very well known, but we're trying to limit as much of that confidentiality issue as possible. The case information is presented to the entire committee, but it is de-identified during those presentations. And everyone does sign a confidentiality agreement prior to attending any of our committee meetings. And we hold our monthly meetings on the second Monday. So as each of those cases are popping up, I'm able to get the information and get those out to the team, like I said, usually within the month. So we have 41 committee members, which is just phenomenal. And those members include the AG's office, we have counseling center personnel, we have DCFS, workforce services. We even have a wonderful person who has lived experience, and she has been amazing. Her perspective is just incredible. So I'm very grateful to have her. We now have local health departments. Those are new to our team, and they have been wonderful. We also have the Office for Domestic and Sexual Violence. We have members of POST. We have members of the courts. We have a member from Restoring Ancestral Winds, from the Stop Abuse Campaign, from the State Board of Education, from the Utah Office of Victims of Crime, the Domestic Violence Coalition, and we do have victim advocates, which are just amazing. So our committee is so awesome, and they've been so responsive. And we were coming together, making all these plans, and everybody was just as passionate as I was about it, and it meant so much. I'm so grateful. So our data providers include the AG's office, the Department of Health and Human Services, of course, the ME's office, the Office for Victims of Crime, the Board of Education, and our victim advocates when they are available. So some of the data that we receive is from the ME's office. We also have toxicology opt-in, law enforcement reports, as I mentioned. Those do take a little while for us to receive, but once we have them, they're invaluable. We also have crime victim reparation claims, which helps. We look a lot at our media and social media accounts, and that is because these cases are often very, very well known in the state, and so we have a lot of information. And we also check court exchange as well. So just some of our case definitions. So IPV is an intimate partner related homicide. So this is an incident where an individual kills a current or former intimate partner. And there are approximately 10 of those homicide incidents every year in Utah. And then as far as domestic violence goes, any DV related homicide is an incident where an individual kills a family member or a roommate. And there are an average of approximately 7 of those incidents every year here in Utah. Now, for the purposes of our review, victims for IPV and DV incidents include both the suspect and the perpetrator. So if we have, for example, a homicide-suicide case, those are both included in our reviews. So cases are identified on a weekly basis, and that's through the OME database, from our records, from death certificates, again, from media and social media, and then from our committee data provider information. So case ascertainment for these cases, it includes a victim who is a Utah resident and 18 years or older at the time of death. The manner of death is designated as a homicide by the ME's office, or the suspect is charged with criminal homicide by law enforcement. So the relationship of the victim and the suspect, this is often a question that we get. The cases that we're looking at includes homicide cases where there was a current or former intimate partner, where they were currently cohabitant, or if they're family members. And this includes in-laws, step-parents, step-children, step-siblings, current or former intimate partner family members, and it also includes foster parents and children. So our goal, I mentioned this several times, but we just want to provide recommendations that will inform prevention efforts. And that's across all of our agencies. We generate recommendations after every case review. That is both the initial review and those in-depth reviews as we kind of hone those in a little bit more. Recommendations are then condensed into action determination as well as next steps. And those are made by me, by my abstractors, by our epidemiologists and evaluators, and also the DVFRC committee members as well. So those recommendations are then tracked and reported. And I have provided to Rachel the report that we have, so you all have access to that. I'm going to go over some of the information that we gathered from that. And then our individual committee members also take those recommendations back to their respective agencies for implementation as well, which has been fantastic. So all this information here is coming from the latest report that our wonderful team put together. And this was published just recently. So again, you'll have access to that. But just so you know a little bit about what we're looking at here. So 22.7 of our homicide victims in Utah died in an intimate partner or domestic violence related incident. And 85.9% of those were female, those victims. But Utahns of all ages are fatality victims of intimate partner related incidents. And 53.9% of those victims had a known intimate partner violence history that was reported to authorities by family members and friends and neighbors. So this is just a look at the types of cases and the counts that we had. We had 138 IPV or DV related homicide incidents, and you can kind of see how they break out there. 85 of those were homicides and 42 of those were suicides, with an additional 4 being of undetermined intent. And this is just a look here at the rates of homicide. You can see through 2009 through 2016. And then just some little figures of interest here. 23% they threatened the use of weapons prior to the homicide. 26 had escalation. 34 had prior threats of harm. 44 had financial problems. 49% of those were murder-suicides. And 54% had a known IPV history. Again, that was reported. And then among the 84 IPV-related incidents, both homicide and suicide, 59% were female, and 69.5% of those victims lived in urban counties on the Wasatch Front. And then here's the age group breakdown. You can kind of take a look as well as their education level. Very interesting. And then here's a breakdown of the homicide versus suicide of those cases. So some examples of the recommendations which have been provided. We have lots of great recommendations. I wanted to bring some of these to you so you know what we're working on. So work with key stakeholders to conduct strategic planning and address the factors that increase the risk for perpetration of IPV and to promote factors that create healthy, sustainable families and communities. Also identify and document known risk factors that exist in each fatality review to ensure the development of informed recommendations focused on shared risk and protective factors and primary prevention strategies. We also have a recommendation to explore the development and implementation of lethality assessments, which I know you're going to be talking about later, which is awesome. And so our specific recommendation was for those in behavioral health centers and hospitals prior to the release of any patient involved in domestic violence or intimate partner violence. We also want to encourage hospitals and clinics to develop policies to conduct lethality assessment on any patient who repeatedly seeks medical care for suspicious injury. And also to increase the accessibility of mental health and substance abuse services for all Utahns. And that's something that I see across all of our fatality reviews. So that is a very important recommendation. We also had a recommendation to provide training to family law and divorce lawyers and their staff on the risks that victims face after filing for divorce, protective orders, and custody orders, and to provide training to those professionals on how to encourage and facilitate contact with the victim advocate and explain the importance of safety planning. This is something that we see so often in our cases. They're in the process of leaving, or they had been talking about leaving, or had filed for divorce. And it's just such a scary time for them. So again, that's a very important recommendation. We're also recommending an increased training to community and faith-based organizations on engaging in appropriate bystander interventions and aiding in navigation to available resources, including connecting at-risk individuals with victim advocates who can help assess lethality and develop safety plans. And to support expansion of the lethality assessment program to all police agencies statewide and establish collaborations with community-based victim services providers and to aid victims in accessing counseling, housing, medical, financial, legal, and other needs. Because we know there are many, many needs that they all have. And this is, again, just a little bit of the information that we got from our report here. So we want to teach safety and healthy relationship skills, engage influential adults and peers, support survivors to increase safety, and strengthen economic supports for families, to create protective environments, and to disrupt developmental pathways toward partner violence. So that is all I have. I'm hoping people have questions. I'm happy to stick around and answer those. And also here is my contact information. Please, please, please don't hesitate to reach out. If you're interested in domestic violence fatality review or have any questions about anything that we're doing.
Are you still there, Casey? Sorry.
I am. No, you're fine. No worries. I'm here.
The muting, the microphones. Do we have any questions in the room or in the chat? Oh, yes. We have a question, Casey, but I'm trying to get the microphone to work.
Oh, great. No worries. I can't see anyone since I'm sharing my screen. So.
I was just wondering the likelihood of when these trainings will be implemented, especially for family law.
I'm sorry, I'm having a little bit of trouble hearing the question.
I was just wondering when some of these trainings will be implemented, especially for like family law trainings.
Oh, so these are the recommendations that we put forth are taken back to the individual agencies. So that will be dependent upon them. What we do as the team is we develop those recommendations, but I mean, I agree with you. I think that's very, very important. And I'm not sure where those individuals are on, you know, as far as implementing those.
Any other questions? Okay, Casey, I don't see any other questions in the room. We appreciate you being here today and giving us some information. It's a good segue into Teresa's practicing. So, and I also think like it's good that you're giving people a little bit of a break so they can like mentally prepare for the practicing that's going to take place. So, thank you for being here today.
Thank you so much. I sure appreciate it. Have a great rest of your day.
Hey, so we get a little bit of an extended break. Let's just come back at 10:15. So get some caffeine.